to develop an intervention to improve the uptake of screening for 3 cancers simultaneously among women 50 to 74 years in rural Ohio and Indiana. And I do have to tell you, this is the first study that was published that focused on the uptake of 3 different cancer screenings in one. And so the 3 we focused on were breast, cervical, and colorectal cancer. And the 2 interventions that we developed and tested were a tailored DVD. I will explain in detail about the DVD. And then compared to the addition of a telephone, so all remote interventions, patient navigation call versus usual care. We'll talk a little bit more about that in a minute. And the goal was to encourage women to get the tests that they needed. They could have needed just cervical or just breast. They could have needed breast and cervical, or they could have needed all 3. So like 7 different combinations they could have needed. And then both at baseline and 1 year after the intervention, we confirmed their status for screening by medical records. And then we also had an aim to look at cost effectiveness. So we called our study Power Through Prevention. This was actually developed in conjunction with our community advisory board for this study. And so let me see. So all of these counties in the pink color, those are rural areas in Indiana, Ohio. There's about 98, 99 of them. And the crosshatched area is 32 counties in Appalachia, Ohio, part of Appalachia, which has additional socioeconomic burdens in addition to rural status. So compared to the United States, residents of the rural counties in these 2 states are mainly white, low income, less educated. And the 32 counties in Appalachia and Ohio were really tightly knit communities, and I've already mentioned socioeconomically distressed. The rates, the incidence rates are near the national average for cancer in these 2 states, but mortality rates exceed the US average. And when you see higher mortality rates, especially for screenable cancer, you automatically know they're diagnosed at late stage and not screened. So the screening rates are lower because of the limited access to care, the socioeconomic factors, and factors related to the social determinants of health, which I have there in that graphic on the right. And we know that early detection with prompt follow-up and treatment for abnormals can help reduce the excess deaths. So just to show you the rate of new cancers for, these are breast in Indiana and Ohio, not, a little higher in Ohio. These are the mortality rates. And you can see again in Ohio, higher than the national average. And you see that color coded, that's those states are part of the Appalachia region that are the darkest color. And then here's cervix. You see West Virginia and in Kentucky with the highest rates. And then look at the similar pattern for death rates from cervical cancer. Again, Appalachia and the South. Here's colon rectum. Are you starting to see some patterns, especially for mortality? Okay, so keep those pictures in mind. These, when we did this study, so we used the 2014 guidelines, so please keep those in mind. That's the time period we did the study. And these were the recommendations for breast, cervical, and colorectal. So please note for cervical, at that time, it only was a PAP. Okay, HPV screening was not approved. And then the prevalence of meeting the guidelines, you can see in Ohio, a little less for mammogram, about the same for PAP and colon. This is for the entire state. We didn't break it down by rural status. But I don't necessarily believe the behavioral risk factor surveillance system data, because it's totally self-report, and it's also a bias sample in terms of who responds. So let me tell you now, with that foundation, that it is a problem in those areas, let me now tell you how we developed our study. So I mentioned our community advisory board. So we contacted residents of these counties we were working in. They came from a variety of backgrounds, as you can see there. We met in person. This was before COVID, so you can see we had a lovely meeting. And somebody asked me about travel in our catchment area. It was the entire state of Ohio. So it was about 2 hours, 2.5 hours to get to this meeting because we made it close to Indiana, so some Indiana people could come. And then we continued to meet during over phone. And they provided feedback on everything, educational material, the visuals, the name of the study, everything. Okay, so this is how a woman would flow through our study. She would be contacted by phone after we identified her, which I'm going to talk in detail about how we did that. Verify eligibility, get consent for the baseline phone survey. Then we got the information about where they get their healthcare. So we have a whole system in my shop about working with healthcare facilities to get medical record verification. Once we confirmed eligibility, meaning they needed one of those tests, we then enrolled them. And we randomized them into these 3 arms. Our study section made us have a usual care arm. And then then throughout the 12 months they were in the study, we did a satisfaction survey. We mailed newsletters to keep participants engaged. And then there was an exit survey. And then we did the medical record review. And then the usual care women, we mailed brochures from NCI. So these are the newsletters. And there was an introductory newsletter, a 6-month newsletter, and an exit newsletter, again, to try to keep them engaged for the whole year they were in the study. And I hope you can see it says Henry County. And we made all of these specific to the individual county that they were in. Yes, it took a lot of time. And wonderful Clarissa on our staff did all these. She looked up all the information, historical information about all these counties. So the Indiana University team was in charge of developing the DVD, again, with feedback from the community advisors and worked with us. So the content on the DVD started with a scripted intro by the physician. And the same physician, a female physician, then did the outro at the end of it. It included interviews with cancer survivors that we filmed. And then we had animations that there still is a digital divide. Today, I can go to Quaker City, turn off the freeway, and there is no cell service the entire time I'm there. A couple of months ago, our mammogram van came this close to not going to Quaker City to do mammograms because there was no internet. They used a hotspot because I was like about to have pitch a fit if they didn't go to my Quaker City. So, and then, women with no internet access can watch a DVD at home, at the library, at a friend's house. And then there was a lot of complicated branching in the DVD that YouTube and Venmo couldn't support. And the cons, there was cost to print and mail the DVD and the lovely jacket. We had no digital tracking. We couldn't tell if someone watched it without asking them. And the new computers, desktop computers at the time, were less likely to include drives and our software to play DVDs. So anyway, we did the DVD, and this is sort of how the DVD was developed. So I'll give you a snippet here for the barriers page. So we knew the barriers. So if you look at individual barriers, lack of knowledge, attitudes, right? And then you have financial, test related, and interpersonal, right? We know those barriers from the literature and from our work. And so on the DVD, the women could select the barriers that they had, say, to getting a mammogram. They could select all those. And then, so you can see like at the bottom, barriers specific to PEP, having a PEP test was cost too much money. That's just an example. So they could check what they agreed with. And then so this is then how it flowed. They got the scripts, we developed the scripts for the intro and the outro. We had to develop the animation. We interviewed survivors. They were real survivors. We had to find the locations and schedule the shoots. Then we did the filming, which included the interviews with the survivors and the physician. We had to do B-roll coding of all those barriers I showed you. So this is sort of, and then we've had to print the jackets in the DVD. So this is sort of how the DVD went. There's the general introduction here, some animation about how cancer happens, and then they do their risk assessment to decide which screening tests they need, and then it goes into all of these different branches. So there's a general outro, and then the breast introduction, and then the breast module they got, and then they left breast if they only needed breast. And so you can see what they would be directed to based on what they said they needed at this risk assessment. So there's something like 200 branch logic, whatever. So let me show you a little bit about the filming. So this is Kathy. She's actually a colorectal cancer survivor, and we filmed her at her house. And this is the that we came up with. The community advisory board felt that something like this would be where rural women could identify. That's the most important thing, is that it had to speak to them. Here is our physician who did the intro. So again, it was plain language explanation of the cancers, risk factor screening. Here's the animation I was talking about that talks about how each cancer forms, and then instructions using your remote or computer mouse to move and select, answer the questions. And here's the risk, which I talked about, like the PAP, would you like to see a mammogram video? Stool blood test. In the past year, if you say no, then you move into that branch. And then here's the colonoscopy one. And so they suggest what sections to review. So for this one, they probably said they needed a mammogram. And so you can see the participant can opt in or out of each section here, the no thank you, etc. Each section here, you can see there are, these are some examples here that what the person said was a barrier for each of these. Each section includes a brief intro from the narrators, is based on their responses. Video clips of the suggested screening tests are shown, and then confidence and intent to screen are then assessed. So this is the breast section, for example. The video explains breast cancer and mammography. Example, barrier would hurt. Some women tell me having a mammogram hurts, although it's painful for a short time. These are things you can do. Let's listen to what Lisa says. So the narrator says this, and Lisa is a breast cancer survivor. And then she gives a little tip right here about you can take Tylenol, etc. And then this is the cervical section explaining it. And then if the person says I planned, then you can get the narration here. And here is Pam that talks about, her barrier was embarrassment and how she got through that barrier. And then here's colon. And then for this one, it explains the advantages and disadvantages of stool blood tests and the colonoscopies. And you could look at both. So here is the video about colon cancer, a cartoon with fit instructions. And here's a barrier example. It's unpleasant. So here again is an advocate who talks a little bit about that barrier and how to get over that barrier. And here's the colonoscopy one. Barrier example is transportation. And here's Kathy again talking about asking her husband to take her daughter or neighbor. Okay, transportation is a huge barrier for colonoscopy. And then a short summary, and then women could revisit any section anytime. So let's go now to the randomization assignments, the study groups. So we had three conditions that we had: the DVD plus patient navigation, and I already mentioned the study section told us we had to have usual care. So it was a 2:1 randomization, stratified by age group and by the 7 screening category, representing which screening test or tests each woman needed. So you can see here the different combinations that each woman could have. Here's what the usual care women got. They received fact sheets and then the exit newsletter. Here's the DVD that they got. We've already been through, so here's the front jacket and the back jacket. It's pretty cute, I think. And then if we added navigation, so after the woman receives the DVD, the navigator called about 7 to 10 days later, asked if they got the DVD, if they reviewed it, if they had any questions, and then any additional barriers they had to screening. Navigators are very well trained. They have resources to help participants schedule the appropriate screening. For example, transportation, needed lower, no cost services. And the navigators recorded everything and documented all the barriers that everybody had and the action that the navigator took. And it might take 1 10-minute phone call for one woman, or the conversation might carry on over a year. Okay. Now let's talk about recruitment. Oh, that is always, right, the bane of our existence here. So when we initially started, okay, we wrote the grant, we were just going to recruit from 32 rural counties, 16 from each state. We weren't actually going in Appalachia because Appalachia has additional problems, right? Okay. So these were our eligibility, all right? And we needed to recruit 1,058 women, right? So we started with our traditional way we have done recruitment forever and a day, which is mailing lists and phone lists, okay? And we mailed recruitment letters to randomly selected residents and followed up with a phone call, over 10 attempts. We had mailed 2,000 letters and only completed 115 phone surveys, and the majority of those were not eligible. So we needed a new approach, okay? So what did we do? So we continued mailing the letters, but we did Facebook advertising, which we paid for. And these are some of the ads that we ran on Facebook. We also did advertising all the places we could think of in communities, newspaper stories, extension office, research match, and Craigslist. We did everything that we could. And so we trained additional phone interviews to accept inbound calls from women recruited from Facebook. And we actually expanded to all 98 counties, rural counties in both states. We stopped mailing the recruitment letters. It just wasn't worth it. And we focused on our Facebook advertising, much to Electra's dismay, because I was not a Facebook user. So this is where our recruitment guide. Now see, there's recruitment only, not good. So then we started PR plus community advertising. And then we did a test run of Facebook in Ohio only. And then we added more rural counties, but not Appalachia. And then we added Facebook advertising Indiana specific. And then we added the Ohio Appalachian counties, and we increased our budget for Facebook. And look at what happened. So the red line's Ohio, the yellow, kind of the mustard brown line or whatever color that is there, is Indiana. And it just took off when we did that, plus community advertising. So we randomized 983 women, more in Ohio. We started a little earlier in Ohio than Indiana. And now I'll talk a little bit about our results. So first paper we published was our response rates and our baseline characteristics. This was like our protocol paper. So from all sources reported that I told you about, these are the numbers of screened. And you can see Facebook was a winner, like almost 3,000 women we screened through Facebook. And this is our participant flow funnel. So we, all in all, we contacted 8,539 participants. You can see the ineligibles over on the left side, the right side. And then we completed the baseline phone call. Remember, that's to establish eligibility on the women, and 1,600 returned the surveys, and we found that 985 were eligible. And then we randomized them, and we actually analyzed 963 with a few ineligibles and 2 withdrawals only, which I think is fabulous, and 1 no exit data. So these are response rates for the baseline, but you see the T1, this is a baseline paper. It's like 89% response rate, 77 on the 2-month, and the exit survey, 83% response rate. I think that's pretty good. So baseline characteristics, I'm not going to go by arm because it really didn't matter so much by arm. But the age of consent, you can see, was about 59 years old. I already gave you the state breakdown. Education is kind of interesting. The highest percentage is some college, or right here. And then income, you know, it was quite interesting. This is not really representative of the income of rural counties. So it's who's on Facebook and who wants to participate. Most of the women were married, and 70% had private insurance, 5% did have no insurance. And as is common in these areas, the majority were white. Working for pay, about half of them, and these are the BMI category, self-report, or if we could get it from the chart, actually, when we went medical record, we got that. Reminders, 63 said, yeah, 60%, are you planning? About half of them. And then I want to draw your attention to the RUCA codes, which is what we used. So 64% came from urban, large, rural, and then 36% were from small and isolated small rural towns. And then this is the Yoast index, which is the lowest socioeconomic stat at 17%, versus look at the highest SCS, like 1 person. So you can see we did have sort of low area income. And then what did they need? So our biggest was they needed colorectal only, but 13% needed colorectal and cervical, and 19% needed all 3 exams at baseline. Okay. So now I'm going to show you our main results, which we published in 2022, I believe. So we have 2 outcomes. What proportion of the women became up to date for all 3 screening tests, right? All 3. There were 0 at the beginning, and then you can see a 12-month window. Overall, it was 20%, but significantly, here's our p-values over here, higher for the combined intervention, 30%. And then for any, meaning, like if you needed breast and cervical, did you get breast or cervical? So at least 1 screening test. We got that up to 36%. Remember, it started at 0, and then moved it up here again, 49% for the combined intervention, which again was statistically significant. And here's our logistic regression model. Again, we did have a statistically significant effect for DVD alone, but for the combined intervention was 5.7% higher likelihood of becoming up to date for all screenings if we had the combined intervention. And what else predicted? Well, based on what you needed, you're more likely to be breast. Because like that odds ratio 19, because everybody knows about breast cancer screening, and it's, you know, it's more common. And then here's some others. The older women were less likely to become up to date with all. And if they had been planning to get screening, they were more likely, as well as self-efficacy, meaning I know how to do it. And if they had more area deprivation, they were less likely to become screened. Now let's move to the other outcome, which is at least 1. Very similar results here, except we lose our statistical significance for the DVD alone, and for the combined interventions, so fourfold increase, or 4 times more likely. Less likely here for colon. See, they don't want to get that colon screening. And the cervical also, which, we can talk a little bit about some barriers there. Then here I've got financial situation. Those who had financial issues were less likely. Remember, I mentioned the social determinants of health. Here's an example of how those who had financial issues were less likely to become screened. And if they were working full time, they were more likely, because probably they had insurance, et cetera. And then planning, again, yes. And again, less likely here with the area deprivation index. So the last aim we had was to talk about cost effectiveness. So the total cost of the DVD intervention, we estimated at $326,000. Additional cost to add patient navigation is about $344,000. So for the DVD arm, it costs $14,000 per up-to-date participant for all. And for the combined arm, it was actually less. Even though it was more intensive intervention, it was less because we got bigger bang for the buck. It's $10,000. And if you look at this cost-effectiveness literature for a lot of cancer procedures, especially, this falls in the ballpark of being cost-effective, about $10,000 per screening. Now, if we were replicating this, the cost of the DVD would be less, because we have all the information. We'll talk a little bit about that then. So I thought I'd show you a few ancillary findings. I hope you might find these interesting. So the first was, because we get questions about, well, did the women really look at the DVD? So remember, I told you they had to, we asked them surveys about if they watched it and what they thought. And we also asked about satisfaction with navigation. So these are some of our process evaluations. So everybody said they received a DVD. 93% said they viewed the DVD. That's pretty good. Pretty good, right? We don't get that on, take your aromatase inhibitor at home. Not everybody's up to 93%, right? Okay, what are some barriers? And here they didn't have a DVD, but many women would go to the library or friends, whatever. And what did they watch? And most of them watched breast and colorectal, right? Breast probably because they knew, and colorectal because they didn't. Did you discuss with others? About half of the women, and mostly with a friend or neighbor or their doctor or healthcare provider. And then among the women who viewed the DVD, I'll just tell you some of the highlights because it's a lot in here, but they found it easy to understand, helpful, and that it gave important information. They did not find it embarrassing or that it was too long. That's really good. They gave trusting information. It was convenient, included women like them, scenes they could relate to, the people they could trust, and it should be sent to other women in their community. And it gave information that needed for all cancers, but especially for colorectal. And it did give them information to help them decide to get screened. And then for patient navigation, 99% received the call. 98% talked with the navigator. Why didn't you talk? See, very few numbers here, no time. What time on colorectal cancer for breast makes perfect sense. And then after talking to the navigator, did you talk to somebody else about this? About half did, and most talked about with a doctor. And then how total number of contacts per participant by a navigator is 22, with a range of 2 to 73 contacts. And then telephone, and the contacts could be other than telephone. So this was 15 telephone contacts from 1 to 48, and mailed. So see, they did mail some things and email them, and etc. So 95% of participants had 1 or more patient encounters here, with the range from 1 to 14. So let's see, total time 22 minutes. and coordinating time, because then they had to do work at home to coordinate what they found. Again, 21 minutes. And then was it helpful? Yes. So again, we had overwhelmingly that it was easy to understand, helpful information that was new, should talk to other women in my community. And I'm not going to go through all of this, but you can see that this is how we kept track, or are now pictorially representing the barriers that were addressed. First, number one was screening was not a priority because I had no symptoms. People do not understand that. And then there were issues with a provider in the healthcare system. I can tell you one story. So I got it. I personally received an email from a woman who thanked me for the study. It said that it saved her life. And the backstory was the woman was exceptionally overweight, obese, didn't feel comfortable going to her physician for her cervical screening. So the navigator said, how about if I find you a female provider close to your house, still taking new patients, will accept your insurance, will you go? Yes, she said. So the navigator did all that. The woman, she went in, actually some precancerous cells were removed, and she said, thank you very much for saving my life. So again, there were different healthcare challenges, and then you can see how the barriers taper off. So for this part, the DVD and the patient, 70% of the women who received the DVD completed this process survey, and almost all the women reported watching it, and they overwhelmingly agree the DVD was helpful. Barriers the navigators dealt with were screening not being a priority, lack of knowledge, and so common cervical cancer barrier was not perceiving to be at risk for cervical cancer. So the last an analysis we did for area deprivation index, which I presented at the World Cancer Congress. So area deprivation index, I hope many of you are familiar with that or have heard of that. It allows for rankings of neighborhoods by socioeconomic disadvantage at the census block group level. So it considers in it income, education, employment, and housing quality using the American Community Survey 5-year estimates, and the University of Wisconsin has it online, and you can see we did this for the 2 states, and the darker the red, the more disadvantaged. So if you remember the map of Appalachia, Ohio, this is Appalachia, Ohio. And what I said that Appalachia has additional socioeconomic distress, you can see right here in the map. So we were interested to see if area deprivation index had an effect on getting screened. And so it does. This is the highest deprived areas right here on the short box in the first all needed screening graph. And you can see the proportion up to date is 14% compared to those in the less socioeconomic distressed areas, 22%. Very statistically significant. And then for any screenings, the same thing, 29% versus 38%. So this is all adjusted for everything. And you can see that the odds of being up to date with either of these measures was significantly lower in the higher distressed areas. We did not find any interaction of area deprivation index with the interventions, which tells us that something extra is needed. An extra intervention is needed in these areas that have high deprivation. So this is basically what I said, but for these areas, you might be saying, well, what's different? They have increased poverty, unemployment, lower education levels that introduce additional layer of barriers to cancer screening. So maybe we can go through a little thoughts about this. So I think you'll see that the DVD was easy to understand, helpful, provided trustworthy, very important information, and gave participants information they needed to make a decision about screening. There was a median of 4 navigation encounters per participant, mostly calls that lasted less than 15 minutes, however. Now, what I didn't show you was a paper we published on self-report versus medical record review, and women often reported over-reported screening, which is another reason why I don't like the behavioral risk factor surveillance system, because people, they telescope behaviors like that, they don't report. A lot of times women don't know if they've gotten a PAP versus pelvic, so they over-report screening. But those with higher knowledge about breast cancer, fewer barriers to mammography, were more likely to accurately report mammograms. The DVD arm participants were almost twice as likely to be up to date with all cancer screenings compared to usual care. Participants in the combined arm were almost 6 times as likely to be up to date with all cancer screening compared to usual care. And then what I just showed you, that residents of areas of high deprivation were less likely to become up to date for all or any of the needed screenings. Few lessons learned, the team. We needed to adapt as needed. Our first recruitment strategy didn't work. We had to do a total 180 and go to Facebook, which is something that we had not used before for recruitment. And then there were some issues with the change in screening guidelines, especially for women 65 and older, that we didn't have enough information from the medical records to clearly delineate if these women truly did need cervical cancer screening. So we actually did a sensitivity analysis where we took those women out, the women 65 and older for cervical, we took them out, made no difference to our final results. We did have challenges with DVDs because many computers are not built with drives to play DVDs. And it's the software is not included with new Windows PC. And they didn't know until they tried to play our DVD. And then we sent them to library or they went someplace and they were able to do that. But women were very receptive to our navigators. We have wonderful navigators and they also come from rural counties. So they knew, they knew what it was like, what the barriers were like that women were facing. And our study was also received very positive. And again, we did the whole thing remotely. I wanted to show you this results newsletter that we put together. Many of the participants expressed interest in learning about the findings. And so we shared this newsletter with all the participants. We mailed it via we mailed it. And it's a plain language description of the study, baseline characteristics, main results, impact, and success stories. And so you can see that we used to explain the results, we used this pictorial approach with little women so that they could see for the results who joined the study, where they came from, their age, and everything, and some quotes here at the bottom. So our next steps. We need to modernize the delivery format, the information on the DVD. And we've been looking at interactive website, a web application, or a mobile application. All of these cost money, upwards of $100,000, which we don't just have lying around anywhere. And we need to determine if we need an offline low-tech version for the women who live in areas without access. We need to update the intervention content to reflect the current body of knowledge and screening recommendations, for example, down to 45 for colon, and also the cervical guidelines have changed. And we'd like to test this more broadly, like we'd like to add lung cancer on this. We'd like to do it in males as well as females. Like to do it in different geographic areas, and especially with different racial and ethnic groups. We received funding from the American Cancer Society to do something local in our federally qualified health centers in Columbus. And we are going to do some sort of a small media intervention. It's not going to be as grandiose as this, but we have some other media interventions out. If you go endbreastcancerohio.org, we have a website there with a risk calculator there that delivers tailored information about genetic screening and testing, mammogram or MRI, et cetera, and age to start. So maybe something along that line, but we're just beginning. So I do want to thank the team, because we could never have done this without our team. Vicki and I were the MPIs. And again, this was funded as an R01 by the National Cancer Institute. And for those, some of you have asked if we published on this. And so we published papers on breast and colorectal, but cervical cancers under review. I believe that paper was sent in. And there's our self-report versus medical record. The methods, I showed you that in the main outcome, and then the process evaluation. So if anybody's interested in looking at it. About 13 minutes. Ah. So we'll start with the room, and I will bring the mic to whoever has questions here.
Start off with a comment first. So thank you so much for coming and spending time with us and delivering this talk. I have two questions. The first one is, how do you know the relative contribution of the DVD? Now, suppose you built a program that was more focused on the navigation without the DVD. Would that be as effective as DVD plus navigation?
Yeah, that's a really good question. We didn't do a 2x2 factorial, so we couldn't test all conditions. So basically all we've done is look at the comparative effectiveness of adding a navigator to the DVD. The problem is that navigation has already been proven alone in other studies. And we know it works. It costs a little more than DVD, which is why we wanted to do this, to see if we could get the same bang for the buck by a DVD, which is less costly.
Because you got a little bit of a bump with the DVD, but a huge bump when
with the navigation.
We don't know if it's just navigation, right? It's DVD plus navigation.
Yeah, but you would subtract if you did an odds ratio for DVD versus DVD plus navigation. That would tell you. Yeah.
And then how many cancers did you actually pick up?
Yeah, so we weren't counting those, so there's really no way we can tell for that. Yeah.
Thank you.
Unless the women, self-reported that they had an abnormal. Yeah. Yeah.
Thank you.
Yeah. In the back.
Hi, thanks. So I have two questions. My first one being your age range starts at 50. Have you done any sort of data or study on younger women or men at that point, if you're going to start trying to do that, as these cancers are affecting younger and younger?
We had to go by guidelines.
Okay, that's fair. I just didn't know if
for younger people at that time.
Moving forward, yeah, I just didn't know if moving forward anything was coming from that. And then my second one is, do you work with any local businesses or the local libraries in those rural areas? Okay, cool.
Yeah, we work with the libraries, and that was a place where one would go and use these, and we advertise at the library, and also the AHEC. We worked with all the AHEC people.
Okay, cool.
Yeah, thanks.
Thank you, Electra. Very nice presentation. So I think one of the challenges of doing this type of behavior is the messaging is, yes, we want folks to get screened, but almost as importantly, we want them to keep screening, right? So intervals. Yeah. And I might have missed it, but I'm wondering with your eligibility criteria, was it women who had never screened, or was it women who were out of cadence with their screening? And
not up to date.
And if you were able, you probably had both, I'm imagining, but were you able to stratify those groups? Because to Rich's point, maybe the women who'd already screened once, the DVD is enough. Maybe those who had never screened needed a little bit more. Were you able to look at that?
I looked at that. No, but all were eligible. It's just you weren't up to date. That's it.
And we have a question online. Marie, I think you can unmute yourself. Try that. And if not, I'll ask the question for you.
Okay. Electra, thank you so much. This was amazing, and I'm bummed that I couldn't be there in person. Patience call. My question is, like, this wasn't a profound effect, but it feels like while you say it's cost effective, it still costs a lot of money to produce the DVDs, keep them current, pay the navigators, the multiple contacts of the navigators. Thinking today and thinking about your future directions, anything you can do or other studies could do to decrease the cost of basically adherence to standard screening?
Yeah, so thank you, Marie, for the question. So first of all, it's not going to cost that much to produce the web. I mean, because we did all the background work already, right? It's just going to be updating some of those guidelines. So that and the price of some of these things has gone down as web apps have become more, utilized, et cetera. The navigation, if you were going to do this in a health setting, soon, I am told by the White House that navigation for screening and follow-up of abnormals will also be covered. Right now, it's only navigation in care, but not then. And so the question then becomes, what are you going to do with the copay? And I don't think that question has been decided. And if this is under the rubric from the Affordable Care Act, that prevention you don't have a copay for, I'm hoping this will fit into that, so that institutions can get reimbursed for the navigator and the patient won't have a copay with a screening.
And that just made me think about another question. I would be hard pressed to suggest that salary, fringe, all of those things are 100% paid for by copays. How do you think we can encourage healthcare institutions to pay for navigators? They're so important, whether it's cancer.
Right. So I am on the American Cancer Society National Navigation Roundtable. A lot of you might know Andy. She's also on there. And for the coverage of navigation. So it's not return on investment 2.6-fold for that, because the person will come in for your services at whatever it is, and then you pay for that. And think about this for colonoscopy. Okay, if you have a 30% no-show rate for colonoscopy, you can't fill those slots that day, right? Because the person has to prep, the wonderful prep. So you're out. You're out for the room, the doctor, and the anesthesiologist, the nurse. You're out for all that money, $1,000 or so, $800 to $1,000. You're out that day. But if you had a navigator who called people, facilitated their barriers, then you're not out that money, right? So, and if you drive people, not literally drive, but drive them with navigation to your health center for those services, and then the downstream effects. We didn't even estimate the downstream effects. Downstream effects is if you're going to find a positive, then you're going to need diagnostic in their family, right? And that's been demonstrated with OBGYN care. A woman comes for her OBGYN care, has a wonderful experience delivery. The children, the family get their health care at that institution. That's why a lot of places invest in wonderful OB suites, right? Because it's a big money maker in terms of the downstream revenue. So I think we need to think of navigation as that you are going to get a return on investment. and make that investment. And my cancer center has. Okay. We have 7 navigators, 5 are mine, 2 are in clinics. One is in leukemia clinic now, and the other is in GYN-onc. The GYN-oncs, they raised money from philanthropy to have that, and for focused on clinical trials, getting patients on clinical trials, addressing the barriers patients have. And then I do have navigators in some non-cancer clinics, the colposcopy clinic and a family practice clinic. But we pay for our navigators because we believe it's the right thing to do for your patients. And it also, we're not losing money.
Thank you. We have another question here in the room.
I'm not even sure if I have a formulation for my question, but I really enjoyed this so much. But I'm finding myself hung up on the DVD and wondering, it seems like it's its own research question in this, and what a challenge it is of how do we then shift towards emerging technologies? How do we know what the community is accessible to the community? And how are you thinking about this going forward?
Yeah, so we've been talking about this. The first is we need to, find somebody who will do it for not an exorbitant amount of money. And then we can easily go to some of our community members, community advisory boards, and see what will work. But, I don't know whether a new Quaker City, really, because, there's no access. And the same holds, we have a study where we're doing symptom monitoring during chemo on smartphones. And we had a deal with Verizon where they would give the patient the cell phone. We would pay for the service for a year so that they could self-monitor. We still had some women who said, no, I don't want that. I want a phone call. So we still have some women who weren't comfortable with the technology. But yeah, so that's kind of where we're moving by phones. And, the phone companies are very willing to do that. They're not going to lose money. They give you last year's model, or the ones we turn in, which I have to get a new phone soon. And, they're not going to lose money because somebody's going to pay for the plan. And a lot of the women will keep the plan. They're hoping they'll keep the plan and pay for it themselves because they like it so much. So anyway, we've got some work to do. But if you went to the endbreastcancerohio.org site, which is another project we have, Turning the Page on Breast Cancer, it is one of those studies that is funded by AstraZeneca now. But it's a website for women to go and get information on their risk for breast cancer, and has a lot of resources. So we're thinking of something like that. And on that one, at the end, you can request to be contacted by a navigator. So something like that is something we might develop. Yeah.
A DVD is 7.6 gigabytes. I think 10 years ago, a thumb drive that was 8 gigabytes, it was probably $100. But now they're less than $1. So why don't you just convert to a thumb drive?
That's an interesting thing too. We haven't thought about that, but that's a great suggestion.
And you can mail it and they can use it any way they want.
Yeah, that's a great suggestion. Thank you very much. We could package it spiffy and everything. We need to update it a little bit first.
We have 1 minute for another question.
Yeah, one more question.
And then we're done, but we have one here in the room. I don't see any others online.
Just kind of continuing with this whole access conversation, but you saw the increase in study participation when you went to Facebook marketing, and that was also in rural communities, right?
Yes.
So they are getting some sort of internet access,
Yes.
right? So is
Yes.
the internet the way to go and Facebook the way to go?
Could be. I'm not, now, does anybody recruit for studies through Facebook here? Yes, you do? Okay, but Facebook has changed now. So we were able to get them to do targeted advertising. They're not going to do that anymore. Yeah, they won't do that anymore. So it might not be as cost effective to do Facebook. Yeah. Yeah. Yeah, we still do. Another study, it's a survey of survivors. And we are using Facebook. We're just in the process now of creating the ads for that one. It's not an intervention, it'll just be a survey, but it's gonna be in multiple states, yeah.
All right, well, thank you very much. Please join me.
Thank you all, and thank you again for that award. That's beautiful. Thank you so much.